So week 6, halfway through, we just took our quiz. Next week is going to be our exam. I'm doing my review tomorrow at 2 p.m. if you want to join me. If not, we can, of course, I'll post it right away. Anybody who wants to review before the exam, please make an appointment to visit with me. Thursdays and Fridays afternoons are pretty good with me. So at least you'll have a couple reviews in there to look at so that we can go over, the concepts that you're going to see. You do have a CJ Sims and you do have NCLEX questions. I was asked by somebody, NCLEX questions, which ones do I do? If you always go to your modules, you hit the NCLEX questions, it's directions. It'll tell you exactly which area, which section to do. So I know I sent somebody those directions today, but just overall, if you're ever wondering, go to your modules, go to that week 6 NCLEX, and you will click on it, and it will show you exactly those areas that they want you to click. And it tells you how to click it on the thing too. So it's pretty good instructions. Now, next week we do our exam. The following week is Memorial Day. So that is off. You do not have class, but the information is important. So you'll be getting early from me week 8's information, which means week 9, you'll have your 5th quiz on week 8 information. Did you understand that, or did I lose all of you?
You lost me. I'm sorry. So the
Next
holiday's
week
on a
is exam.
Monday. The
Hmm?
holiday's on a Monday, so we don't have class on a
Oh,
Tuesday?
that's right. You're Tuesday. Never mind. I'm confused. I'm Chanel, thank you. No, right. We're Tuesday. It is okay, but you still will not have a quiz on week 8 because we are not going to give it when you can't do it on Monday. It'll be week 9. If you look at your syllabus, it shows you week 8, there's a quiz. It is Memorial Day week. We do not give it to all classes and leave out one class that are not taking, the class that week. So we do it the following week. So week 8's information will be on that exam for week 9's quiz 5. And I'm going to put it in an announcement for you to see and to look at. Sometimes it's you look at it, you can see it, you understand it.
Okay, so to clarify, we have an exam next Tuesday. The
Correct.
following Tuesday is just lecture. The
You're right.
following,
No quiz.
and then that'll be week 9, we have a quiz. Week 10, we have an exam. Week
And
11,
week
we
11
have,
is HESI.
and then it's HESI. Okay,
Yes. And
thank
then
you.
it's just your remediation. No, you're very welcome, Courtney. Thank you. That made it very clear for everybody.
And one more thing, just to clarify about the was I correct about the pediatrics and cardiovascular and throat and respiratory NCLEX questions?
Yes, yes, yes,
Okay,
yes, yes, yes.
okay,
That's
okay,
exactly what I saw in it when I went and looked at it. So
okay.
yes, just to let you know.
Yeah, because it said something about week 5. I got a little bit off a little bit, but this is week
That's
6.
okay. I'm
Yeah.
confused. I haven't felt well. I've had a little GI bug, so I'm a little bit dizzy, but we're gonna make it through it.
Okay. Thank you.
No, you're very welcome. Anybody else with a question? All right, let's go ahead. Let's start our PowerPoint tonight. So tonight we're doing hematology, immunology, and a little bit of other stuff. Hematology, it's all about blood. It's all about the components of the blood. And when we talk about components and what we're measuring, we're going to measure white blood cells, red blood cells, hemoglobin, hematocrit, and your platelets. And we will talk about bleeding coagulopathies, your PTs, okay? So that's your bleeding and a CBC. And that stuff is going to tell you something. So you get a child that comes in and they are telling you they're tired. They are exhausted. They are not as energetic. They don't want to do things. They might look pale, they may not, depending on the child and their normal coloring anyway. So how do we go and evaluate that child? Well, always number one, what did the parents tell you? They're telling you the child's tired. Then you do that complete history physical. Let's look over. Is the heart beating fast? With anemia, your heart tries to beat faster, right? Because what do red blood cells carry in the body? It carries iron and it carries oxygen. So if you don't have red blood cells, which are, you don't have enough, that's anemia, you don't have those oxygen, that iron in there, the body does not perform as well as it should, right? So we're going to say, uh, when did this start? Has it been going on for a while? We're going to go over diet. Diet can affect it, especially your toddlers, right? Toddlers are always iron deficient anemia because of their picky eaters. And then we're going to do a physical. And that physical is going to show you some things. Your heart's going to be beating faster. You might even hear a murmur in there swishing around because the cells are so loose, it makes a instead of cha-chung, cha-chung, it's like this swooshing sound that goes on. And you can hear that murmur with anemia. So, you know, another thing is the immunological dysfunction. And we'll be looking at the neutrophils. We'll be looking at white blood cells and saying, has he been sick a lot lately? Or has they been bleeding, nosebleeds, just normal hematomas, petechiae, and are there any extras? So with anemia, we know the iron and oxygen carrying capacity of the blood goes down a lot. And with that, we know that children are, get tired and weak, and that's what they complain of. Now, it could be anemia due to just dietary, but it could be due to many other things. And I'm going to go into what the names of those things are. But usually you think of anemia, it's iron deficient anemia. How do we correct it? Change the diet, or we give iron to that child, right? With children, they say hemoglobin less than 10 would be anemic. That wouldn't be with adults. It would be a lot less. So children, we want their hemoglobin hematocrit to be higher. As I said, when you get anemic, you don't have oxygen, you don't have nutrients to the cells. So you have all of this fluid and a couple cells, and as it swishes through, again, you're going to hear that big, big murmur. If we do not correct that anemia, that heart's going to beat really hard, trying to get oxygen and iron to the body, and it can't. So cardiac failure can occur because you're not getting the nutrients, iron, that growth retardation is a part of it. And of course, you can think cognition too, no oxygen, right? So types of anemia. This is right out of your book. It's one of your pages. There's decreased red blood cell production, increased loss, or increased red blood cell destruction. So there's different names for them, but basically they all are decreased red blood cells, decreased oxygen, decreased iron in the blood, and all of it that goes with it, okay? So the decreased red blood cell production. You don't eat properly, you don't have this in your body's not going to produce red blood cells. B12, right? The intrinsic factor, that's part of your iron, your red blood cells, iron and the other ones too. Bone marrow failure. One of the things, the bone marrow produces red blood cells, and sometimes the bone marrow just doesn't. Now, aplastic anemia, I'm going to go into it a little bit because it's white blood cells, red blood cells, and platelets are all depressed in this child. So very sick child. This usually occurs in things like leukemia. Think about what is ALL, AML. This is leukemia where white blood cells are low. And then because white blood cells are low, you're also destroying red blood cells and platelets, and it all comes together. And it looks almost like an aplastic anemia. And actually, the treatment is the same as leukemia with chemotherapy agents. Now, increased red blood cell loss. I think this is the one. Parents come in, child's having multiple nosebleeds, epistaxis, or they're seeing bruising, the petechiae on the body, and they're like, this kid just sits playing video games all day. Like, what's going on? Why are the bruises here? There's no kids in the house. He doesn't bump into anything. So we'll be looking at it. These are little signs. Those little signs tell us something with the bleeding coagulopathy is not working. And the first place we're going to look is a CBC, and we're going to look at a platelet count. Now, With epistaxis, I have seen multiple children come in that are having a lot of nosebleeds. You know, they do all of the stuff they're supposed to. They paint the nose, they this, to that, and it continues. So they come in usually then to the emergency room and they draw a blood. And they find, usually with epistaxis, you'll see platelet counts below 20,000. This is something that we call ITP, idiopathic thrombocytopenia purpura, or just basically low platelet count. You don't have platelets, your blood's not going to clot. You're going to have epistaxis, nosebleeds, petechiae, and stuff. We're going to go into treatment in a second. Hemophilia, we know that's a factor of the bleeding coagulopathy that's not there. And there's multiple factors. Factor 8, factor 9, von Willebrand's. We're going to talk about that. Then we talk about increased red blood cell destruction. You know, we've heard of sickle cell disease, and they're those little sickle-shaped cells, and they don't live long and they burst. So sickle cell children, even adults that are in crisis, are bursting so many cells. Their red blood cells are so low. It is very uncommon to have a child walk into the emergency room in a sickle crisis to see a hemoglobin above 7. Usually they're 5 and 6. And you're immediately giving blood in the emergency room. Why do we give it immediately? Lack of oxygen, right? To that child. We need to get that heart's beating like crazy trying to pump. We need to get the volume back in, get the oxygen back in, you know, and take care of that child as they need it. There's something called G6PD. You learned it. It's on one little picture this big in your pharmacology book. It is a medicine that has glucose in it. And if a child drinks glucose sugar, they have red blood cells hemolysis. They burst. So they need different medicines. I had one parent. I was in the emergency room and the mother said this child had G6PD. And I went, I don't know what that is. So she explained it to me, and I had to give that child something for a fever. So I had to call the pharmacy and get a ibuprofen that didn't have sugar in it. Believe it or not, that's a G6PD. You're not going to see all these things, but it just keep your mind open to this stuff. Now, the other part is when you have this overwhelming infection, you know, your immunological system is just down. It could be due to chemotherapy, radiation, could be just drugs. And again, red blood cell destruction like crazy. So now let's go into let's managing all of this anemia. So we've done our history, physical, we've done our CBC, and we have our numbers. So if my hemoglobin is a 5, I'm going to give that transfusion right away, right? I'm going to make sure I get that blood level up. So, but think about it. Put the blood transfusion in, the body's good, hemoglobin, hematocrit come up, heart rate come down, everybody's happy. And then, is that condition still there, like sickle cell or thalassemia or one of those? And then the cells die and it goes down. So they're up and down with their hemoglobin and hematocrits. This plays havoc on the heart because it's up and down. The heart rate's up, it's down, it's exercising, not exercising, if you can imagine. And the other thing we're going to do is just to give a little bit of volume. So IV fluids, and they're going to give some oxygen. And I'm going to tell you honestly, if you don't have red blood cells, is extra oxygen really going to work? And this was posed to me as a question by a physician with, I was treating a sickle cell child with low hemoglobin hematocrit. He said, you can put it on, but it's really not going to do anything. You don't have any cells to carry it. So, but anyway, another quandary to think about. And again, resting. We're going to save all our energy, right? Another thing that we look at, how old's the child? And let's look at the racial or ethnic background. I mean, African American, sickle cell, thalassemia is the Mediterranean descent. So if we see these things, we could put pieces together. If we have to do any sort of lab work on a child, especially if they're a chronic illness like sickle cell, please get that kid prepared. Let them know what's going to go on and try to be as painless as possible on these children because they're going to be in and out of the hospital for their lives. And you have one person makes a child afraid. It takes a lot to get that child calm as we continue to treat that kid, right? Also, do you want that kid screaming and yelling and going crazy just to draw a lab or start an IV? They have no reserve. You don't want to do that. You want to decrease their oxygen needs. You want them quiet, sitting on mom's lap if they want. So iron deficient anemia, I did mention this is dietary. This is those green leafy vegetables, right? Now, biggest group of children that get iron deficient anemia are toddlers. I've already mentioned it once. These children don't eat a lot. You know, babies eat like crazy and they grow like crazy and they become 1 year old and all of a sudden they're not eating. And parents are like, oh my God, they're not eating. They used to eat a lot better. They're not growing as much. These children know they don't, but then they become picky. Their taste buds start to taste and they don't like some food. So this is where, that iron deficient anemia comes in, right? Another type of anemia is those adolescents. Remember, they grab a power bar and they grab a bottle of water, go out for the day and save their money, and they're too fat, so they want to lose weight, and they're growing that big growth spurt there, right? They're not getting their nutrition. So again, this is an area where iron deficient anemia is that young adolescent. Milk babies is what we call giving a infant under the age of 1 year old whole milk, not formula or breast milk. They're not getting the iron and calcium stuff they need in the breast milk or in their formula. They're not getting everything they need. So that's what milk babies is. So how do we treat iron deficient anemia? It's a dietary problem. We're going to feed them and we're going to be giving iron. Remember how to give iron. There's some NCLEX questions on it. There is always hefty questions on iron supplementation. Remember, iron's given on an empty stomach. Iron has to be metabolized by acid for it to be useful. So the stomach acid starts that. Also, no milk. You don't want to coat that stomach. Orange juice through a straw so they don't get their teeth all brown, right? And remember, their stools will turn black. This is what we tell parents. So sickle cell anemia, it is carried on African Americans, and we know that if both parents have just the trait, not the disease, the trait, each child has a 25% chance of having the disease, not the trait. If you have the trait, you're not sickle cell. You just have to be careful going forward if you're having children because you could pass it on. Okay, let me try to explain sickle cell anemia to you and the treatment. So, what is our concern with sickle cell anemia? Well, what happens is this. There comes a time where your blood vessels become shrunk. Could be you're dehydrated out in the sun, you're not drinking, you're sick, any of those things. And those blood vessels become skinny. And these little sickle-shaped little cells are going down all over the body and gets to a bifurcation in a vessel. And right at the bifurcation, the sickle cell covers it. And then no more cells can get through. So they back up on top of each other. So blood's not going down, it's staying up and it's filling up that blood vessel. It's going into the tissue, creating pain, redness, and swelling. So how do you think we would treat that? We could treat the pain, it hurts, but we're treating the symptom. What's the cause? Little tiny blood vessels. So what would be the first thing we do? We're going to bolus normal saline. Bolus fluids, dilate those blood vessels, right? And then put heat on the area. Again, it dilates and doesn't constrict. It makes those blood vessels as big as they can. If you don't open it up quick distally, you're going to have no blood flow, and it could be, that local hypoxia and those cell death. Could be fingertips, could be toes, it could be anything. So these are the things that cause sickle cell. Anything that makes a need for oxygen more, trauma, any injury, infections, fever, because now you are more dehydrated. Blood vessels are getting smaller. Physical, emotional stress absolutely causes any disease to get worse. And then, of course, dehydration is the big thing. I mean, if we have a kid going out to play any sport and he has sickle cell disease, this is a child that needs to carry a water bottle with him at all times and needs to keep extremely hydrated. I mean, a diabetic child, you'd have a little candy bar or checking his blood sugar before, but sickle cell, you want to make sure they have all of that fluid in them. Keep it going, because once that vessel dilates, that sickle cell moves, then the blood starts flowing, the pain disappears, et cetera, et cetera. So rest, hydrate, give something for pain, a lot of, and the heat, of course. And a lot of times there is a low potassiums on these children with the sickle cell. So again, we'll be monitoring that. It's not priority. Our priority is blood if we need it for that anemia. And if they have an infection, antibiotics. Those are more priority than your electrolyte, your potassium right now. Now, young children, we know don't have any immune system. So what they do is from 2 months to 5 years, they put them on what we call prophylactic antibiotics. It's one time a day. We do these for children who don't have spleens, that their immune systems are lower. We do these for sickle cell. They're immunosuppressed. We give them, it's one penicillin, it's a PenVK, and they give it one time a day, and that helps fight and keeps them away from infection. Also, they'll be looking at reticulocyte counts. Is the bone marrow working and how is it working? Very closely monitoring of that. And as I said, blood transfusions, it gets oxygen, iron right to the cells. And this is what the body needs to reduce that hypoxemia or ischemia. Now, there's no cure, and we try to, with sickle cell children, adults, at first symptoms, get treatment. Don't wait. Don't wait until you have a fever. Don't wait until you go into crisis. Be very proactive, keeping, yourselves hydrated, knowing if you're having an infection, be in front of it instead of waiting on it. Leading cause of death in the young children with sickle cell is bacterial infections. Again, immunosuppressed, right? They don't have the defense. Then they get the infections, and then they get fever, and then they get dehydrated. Then they go into sickle crisis, and you could see how it just goes on and on and on. Sickle cell people can live, they say fifth decade, they can live a lot more, depending. They keep hydrated, keep themselves, and, aware of their bodies. So early intervention, give penicillin to those children. And then you can see things like chest pain that looks like a pulmonary embolus, or you can see headaches, which could resemble strokes. Be aware to look if you have a child with sickle cell complaining of a headache or respiratory problems, investigate it further. Is it a sickle cell crisis? Is it a stroke? What's happening? So that we can get treatment even quicker than we normally do. Again, treat these kids normally, just have a water bottle in your hand, right? To prevent that sickling. Now, sickle cell was a sickle-shaped cell, right? Thalassemia is Mediterranean people, and it's a rectangular shaped cell. The problem with thalassemia, these cells they're born a little shaped weird, which is not a problem with the blood flowing and anything, but these cells burst. They don't last long and they burst inside the blood vessels. What is inside those blood vessels? Oxygen, that's not what I'm worried about. Iron. These children can go into um, iron overload and need some sort of treatment to get gelation therapy to get rid of that iron. Now, there's 4 types of thalassemia. When we do and talk about thalassemia, we talk about Cooley's anemia, the most severe. This is the one where your blood cells are always exploding, right? There's nothing we can do to stop that. So we only can treat the symptom, which is anemia, and treat it with transfusions to live. So thalassemia at birth, we don't necessarily see. It's usually about 6 weeks old, their cells change. And it's usually because we see child's not growing well or looks anemic, that we look at that blood cell to see what's going on there and we recognize what's happening. Okay. Because usually at birth it's mom, and then the baby's blood body takes over by then. Again, how do we treat it? Blood transfusions. So again, blood transfusion, I lose them all. Like they're die. Blood transfusion, I lose them, they're die. It's like my heart works good, it doesn't work. It working overload. Working really good, working overload. So this is one that usually heart failure is what usually is their death sentence, because of the amount of blood that they have to take in order to keep their hemoglobin elevated. Because of the iron exploding in there, they do that chelation therapy, whether it is desferal, or they can do a machine called an apheresis. And all it does, it pulls off the cells, the bad cells there, and that the iron, and it tends to work with that iron. So what do we need to do for that child with thalassemia? Well, this child's going to be having transfusions all the time. This child needs to be prepared for all of that. This child and family are constantly in and out of therapies, blood transfusions, et cetera, et cetera. And then think about that person who's having multiple blood transfusions. Now, you would ask, how often do they get blood transfusions? Sometimes they're one a week, 2 a week, once a month. It all depends on the person. So that's, a number I can't give you an exacting number on, but they're getting a lot of blood transfusions over their life. And with that, you have to think about blood transfusion reactions. Thalassemia people can live, if they're given all of those blood transfusions and monitored really closely. But as I said, heart disease is usually what, is the normal cause of death. Many times they want to take the spleen out to stop those cells from being produced, and that can cause a sepsis. They're immunosuppressed. And then, of course, they go into multi-organ failure. And, again, with thalassemia, just like sickle cell, maybe bone marrow transplant will help. I've seen one on a sickle cell that one worked, one didn't. So, it all depends. So this is aplastic anemia. This is the one I told you. It's depression of white blood cells, red blood cells, and platelets. When we talk about aplastic anemia, it's the hypoplastic anemia, right? It's the pancocytopenia. It's like where all of the cells are gone. So this child is set up for infection, set up to bleed, and has no energy because it has no red blood cells, oxygen, or iron. As I said before, these children, because all of the way that things are going on here, it's very similar to leukemia. So they treat it with immunosuppressive therapy or a bone marrow transplant, and that's usually the treatment for that. So let's look at bleeding stuff. Hemophilia. Hemophilia is an X-linked recessive trait. That means mommy has given this to the baby. There are hemophilia A, B, and von Willebrand, what we talk about. Now, there's a lot of other bleeding discrepancies, but we're not going to talk about how many there could be. These are the big three. Hemophilia A is the normal. It's the classic. It's that factor 8. That means in the blood, you need this and this and this and a factor 8 to clot. There is no factor 8, so the blood doesn't clot, okay? Whether it's factor 8 or hemophilia B, factor 9, or von Willebrand. Now, von Willebrand is also two factors. It's factor 8 and something else. There's another piece of a clotting cascade that is missing, and that's the von Willebrand. So looking at children with hemophilia, we don't always know all the time that these children have it or suspect it. What would we see? Well, this would be that child that would be having that epistaxis, would be having all of these bruising, just when bleeding, getting cut really bleeds a long time. One of our biggest worries in hemophilia, especially in children, is they like to go out, they like to play, they fall down, they bang their elbow, their knee, and now they've got a big hematoma in their knee, a hemarthrosis. That could cause a lot of knee damage and irritation, and it could cause a problem with being crippled later on in life. So we don't want to keep that blood there. So we get the child in, we see all of these bleeding and stuff, and we've listened to it. All right, what are we going to do? Well, we're going to draw some lab works. We will draw all the factors, and we will draw a CBC and a parathyroid hormone and a fibrinogen level. Now, factors take over a week to come back from the specialty lab. But when you see the platelet counts low, you're going to say, okay, we see it normal. Okay. And then you look at the other two, parathyroid hormone and the fibrinogen, we're going to say, now we know what's going on, and we could wait, let's see which factor it is and then treat it. Now, replacing this factor, I've seen children get home infusions. I had a little 8-year-old or 9-year-old boy came in. He fell down, his knee was bruised and it was swollen. It was on a Saturday and they couldn't get a hold of his hematologist. So they came into the ER, his dad and him, and they asked, do we give it? We don't know. So the doctor said, no, yeah, go ahead. We're going to give it. The father asked me, can I give it to him? And I went, why not? I said, do you mind if I watched? And I had a orientee with me, a brand new nurse. So she was excited to watch this father do this. I want you to know that that father did it better than most nurses do. That son and that father, the son picked out the vein. He held the butterfly there. I watched him wash his hand, use alcohol, mix up this stuff because it's a powder and a liquid that you have to mix back and forth, pull it in a syringe, put it in a tubing, and then push it slowly. It was amazing. So what do we do with home infusions? If we have a child at home who, all of a sudden, falls down, we can give a home infusion right then and there. I mean, this is, the thing. We heard about rice, all about orthopedic injuries. Well, let's put it one more. Let's put it a P for protect. What if you get a toddler, all of a sudden you found out they had hemophilia? You'd have to protect that whole household, right? I mean, look about the sharp corners on your coffee tables or chairs or books or things sticking out, and you're worried about bleeding. So you would be padding these things for that child. And of course, if they fall down, you see the bleeding like into the knee. Number one, stop, rest, ice it, ace bandage it, and elevate it. And if there's home therapy, again, to give it in order to stop the bleeding and stop that crippling effects of the bleeding, because those joint sacks get irritated and damaged, and then they're not going to be able to walk. So philia people can live pretty normal. As long as if they're bleeding, make sure we take care of the joints, we give the therapy soon, and hopefully they're going to have that gene therapy pretty soon to be able to help that. Now, ITP, immune thrombocytopenia purpura. It's a big long name. Just call it ITP. P for platelets. That means platelets are low. You're going to see thrombocytopenia. That's another word for low platelets. You're going to see purpura, and you're going to see bruising, tiny little purple looking, almost like that arm. I've seen it on children on their legs. And this is the kid. They're never going outside. I don't know what's going on here. And you see this bruising. One of the things you might have seen, these children have upper respiratory infections that usually you're going to see it like, 3 weeks afterwards. All of a sudden, they have all of this bruising and they do the CBC. They see the low platelet counts. Yeah, they had some sort of upper respiratory, some sort of infection going on, and it caused it. Now, ITP, once we diagnose it, these children will be put in the hospital to do the initial treatments, to make sure there's nothing else going on, of course. They're going to be given IV immunoglobulin and anti-D. Now, nursing care, nursing responsibility. Well, you have a child with a low platelet count. Low platelet counts can cause bleeding. So, number one, you're going to teach that child how not to cut themselves or to be careful with whatever. If it's an adolescent, no shaving. Adolescent girl, I'm sorry, you can't shave your legs in the hospital, only when you go home. I don't want to see bleeding, right? This is things that you have to teach. If you have to give IMs or sub-Qs, you will avoid them as much as possible. We try to make those IVs as much as we can because they'll bruise, they'll bleed forever. You'll be monitoring for bleeding and you'll be watching. They'll usually do daily CBC counts. So you want to watch that platelet count. Is it coming up? Is it coming up? Is it coming up? And then sometimes corticosteroids are prescribed. So and most of the time it's corticosteroids. So that's your treatment for ITP. Now, epistaxis. You're going to have an NCLEX question on this one. What do? A kid is all of a sudden their nose is bleeding for whatever reason. They hit it or it's just happened. Kid is going to freak out, especially younger children. They're bleeding to death. So when they're freaking out, what's going on? That child's heart rate's up, they're screaming, bleeding is going to be more, blood pressure's up. So try to calm the child down, okay? Take your thumb and forefinger, put it on the bridge of the nose, and you're going to lean them forward. If you put them back, they're going to be swallowing the blood, and they'll vomit blood, and they'll just keep bleeding. So bring it forward. If after 10 minutes they're still bleeding, you need to get them to treatment because they might need them cauterized or other packing put in there or something. It's too long. And why is it bleeding that long? Is it an ITP that we don't know about yet? And HIV/AIDS, this is your immune part of this. The one way that we're concerned HIV/AIDS is a lot of either infants or adolescents that are in risky behaviors. Now, in infants, we do have infants born in the newborn ICU. I worked there for many, many years, and the mothers are HIV positive. So what is our responsibility and what do we need to do for this child? Well, number one is there is an HAART treatment, a highly active antiretroviral treatment. And they usually try to start that about 22 weeks and then even to birth. Our goal when that baby is born is to do everything we can to improve their immune system. Now, you're going to say that once they're born HIV, that they're forever HIV. I've seen them seroconvert by 1-year-old with antivirals. I've also seen triplets. One had AIDS, one had HIV, and one was perfectly normal. Who knows? But those are the things that can happen. So prognosis on them, if we get them early, we improve that immune system as quick as we can, and we be aware of those things. I mean, adults, children, pneumocystic pneumonia, it's part of HIV/AIDS, right? We'd be watching out for yeast. Adults, children, same thing. We're going to be watching for that yeast, and we're going to be watching out, especially in children, pneumocystic pneumonia, because their lungs are very, very tender. So the thing with HIV/AIDS is the education, and especially education for those adolescents. And then with your infants, just making sure we improve their immune health as much as we can. So with hematological immunological disorders, we're going to be giving a bunch of blood products. Remember, a transfusion reaction. The one thing about transfusions, there's always policies how to give it. I know that if I'm giving it over 4 hours by policy, I had to take vital signs before I started the transfusion, double nurse check it, of course, and 15 minutes later, I had to retake a set of vital signs. Now, yes, my nursing assistant, somebody working with me could take that, but that's usually when it happens in that first little bit. And sometimes it's just a simple from a 98 temperature up to 101, and that's a reaction. So what do you do first? You suspect a reaction. Turn off the blood. Number one, get rid of it, all right? And then, call the physician and see what you need to do with that right there, okay? I mentioned earlier apheresis. It looks like a dialysis machine, but it just removes certain components out of the blood. Nurses run this. In our hospital, we had several nurses that were trained in order just to do the apheresis, and they could take just the iron off of that child with like thalassemia. Another thing we do is bone marrow aspirations. Have you ever seen a bone marrow aspiration? Have anybody ever been in a room with it? Let me tell you what it is. Number one, they could do it in the chest, they can do it in the hip, in the iliac crest. The thing with bone marrow, yes, they'll numb the area, they'll put numbing in there. But you see that blue thing that's sticking there? It's like a stick with a T on top. And they hold the top and they have to get into the bone, and you hear that sound. Prepare that patient if they're older. And a child, sing a song or something so they don't hear it. Many times children are sedated for this. The one thing is it hurts no matter how much, infusion of lidocaine, topical, it does hurt. So with children, tell them it's going to hurt, but you'll do everything to make it as little as possible. Don't lie to a child. They'd rather know than not. So if both parents have a sickle cell trait, what's the chance that each of their child will have sickle cell anemia?
A, 25%.
It is 25%. 2 with a trait makes 1 with the disease. So we have some about cancer too. Neoplastic disease, lymphomas, and leukemia. Bloodborne is it's a lot, children. What is leukemia? Well, leukemia is where there's a malignancy in the bone marrow and the lymph system, and your body's whole white blood cells shut down, and it needs to be, of course, treated aggressively. It is more in boys. Down's syndrome. Do you see this? They're up for congenital heart disease, right? But Down syndrome children are a higher risk for leukemia. They're also higher risk for hypothyroidism. These poor children, you have to really monitor all of these diseases in them. Leukemias we find in children, they're usually right around ages 2 to 5. It's a hard time for a parent to deal with, and it's a hard time for the child to deal with. They call leukemia the unrestricted proliferation of immature white blood cells in a blood-forming tissue, which means you have blood cells, white blood cells are being made, they're worthless, they don't work. What type of white blood cell count do you think a child with leukemia would have when they first find it? Well, what are normal white blood cell counts? 7 is a great one. 7 to 10 is, a good one, depending on the scale of the lab. Children with leukemia are below 1, like 0.1. That means there's no white blood cells. You don't have any white blood cells, you don't fight any infections. So, how do you diagnose leukemia? Well, I had a very good friend whose daughter was always played with my kids in the yard. And all of a sudden I found out she was in the hospital and had leukemia. What I found out her symptoms were, and it's textbooked, child felt weak, tired, saw some bruising, had a fever, and had really bad pain in her knees. And she went to the ER. And what they did is a CBC. Again, but they did a smear on the cells to look at them, and they did see that those leukocytes were all immature and they weren't good. Also, hemoglobin hematocrit were very, 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 very low. I mean, that girl today is a PhD in psychology. She's done well. It's a few years ago now, obviously, but leukemia outcomes are so much better than they ever were. So once we decide you have leukemia, they're going to do a lumbar puncture. They want to make sure, is there anything in the central nervous system? They're going to do that bone marrow. They want to look at the cells being produced, all right? And again, be honest, it does hurt. Now, in leukemia, it's pretty quick once we decide you have leukemia. They're going to put in a central port, which means you don't have to have IV stuck in you all the time. It's something they put under the skin and the upper chest. And every time they come in, we just numb it. And it's no big deal for these children. So the first 4 to 6 weeks, these children are hit with what we call big gun chemotherapeutic agents. It could be 1, 2, 3. It depends on the cancer, how far, and all of those things. And the first 4 to 6 weeks, they just load this child up. The goal is remission. And you're thinking remission after 4 to 6 weeks? Yes, that is the goal. But we're not stopping there. We're going to central nervous system prophylactic, do something to make sure nothing's hiding, because cells can hide. Also, in the body, are there any of these cells, these cancer cells in there hiding? And they go in there and do consolidation and maintenance therapy to keep it gone. But it's the first 4 to 6 weeks, which are the most critical. Now, sometimes, no matter what you do, leukemia doesn't go away, and they're going to need a hematopoietic stem cell transplantation. Now, thing about these things is you don't have to have it like a blood match. It doesn't have to be an A positive with an A positive. Doesn't matter. Okay, it doesn't matter. It's antigen matched or mismatched. Those that don't matter. It doesn't matter relative, non-relative. The best blood, if you can have it, is your own, which would be probably in a baby, their cord blood, right? That you did save. That is what we call an autologous, or automatically my blood cells are better than the other people. Now, if I don't have any of my, cord blood on file, I just didn't do it, it was too expensive, then it's all of the others, allogenic. So the way you remember these two, autologous, which is my stuff, automatically mine is the best. I want that. And if I can't, allogenic, all the others will work. And that's how you remember those both. Now, leukemia, again, it does hurt. It is intense. They're going to be going through in all, sorts of things. They're going to be getting infections. They're going to have hemorrhages. They're going to be anemic. They're going to be in pain, all of these things. And they're being in and out of the hospital, in and out of the doctor, in and out of the ER. So again, prepare these children and family what's going to be going on, making sure they're comfortable, their pain is relieved, and prevent things like that infection. And that's just simple hand washing, using gloves, putting a mask on, or whatever. Those little things make a big thing. And also, if you are that nurse on the oncology floor, you got to be careful with those chemotherapeutic agents. This is probably one of the highest paid jobs. You get a little bit of experience and do chemotherapy agents. These are jobs that nurses can get sign-on bonuses, $25,000. Pediatric oncology, but then you have to work with, children with cancer, which is hard, but it's also very rewarding. So prognosis of leukemia, we know that if the initial blood count was good, it was not like 0.001. You're going to be doing better. How old were you? If you're younger, you actually do better. And what sort of cell? I mean, we've heard of AML and ALL. Depends on what white blood cell that we're involved with. The ALL is easier to cure. Boys or girls, and then this karyotype. What's your blood type? You're going to be getting a lot of blood products. So if you have it ready available, it helps. know that cancer, we do different things depending, we can do surgery, we can do chemo, we can do radiation, we can do chemo and radiation to shrink things in order to do surgery. It's done all different ways, right? So children that are undergoing this, remember, they're going to be in pain, they're going to have fever, they're going to be, bruising, bleeding, they're going to be exhausted. And these are things that, we have to remember. Now, the treatment, chemotherapy, we've gone in there and we're going to be giving and hit them with a really broad spectrum chemotherapy, and we're really lowering, all of, their body functions. And sometimes we call it, there's this nadir period where children's neutrophil counts go really low. Now, what are neutrophils? They're white blood cells. White blood cells fight infection, right? So if your neutrophil count should be above 1,500, 2,000, and you see that it's 500 or less, this child does not have an immune system. This would be a child that if you had a group of patients and no matter what if they had cancer or if they had bowel obstruction or if they had anything else, you see a low neutrophil count, this is a child which is about to go into septic shock. That's how sick these children are. So this would be a child, then they have a fever on top of it. I'm going to see that child first, call the doctor, and we need to get, all sorts of specimens collected, and we're going to be giving broad spectrum antibiotics as soon as we can, because these children will crash because they have no immune system to fight anything. So the thing about these, giving the treatment, it's, giving the hemorrhage that can occur with it. We're going to have to be giving all of these infusions, etc. I think nursing is teaching child family is to keep this kid from riding the bike, skateboards, contact sports, right? This again, another one, put them in the swimming pool. They usually can't get cut and hurt in there, right? And again, remember, if they're anemic, they don't have energy. So again, remember that as we're doing, even just daily, doing, giving them a bath or cleaning their rooms or, giving them time to do things. They're very, really tired. Making sure we give those antiemetics before we start therapy. Years ago, I couldn't give an antiemetic until that patient vomited. Change in practice today, isn't it? We prevent it instead of waiting for it. And I like that thought. Remember, they're not going to want to eat at all. They're nauseous. Some of them are vomiting. So how are we going to be monitoring these children? Remember, children need nutrition. How do you monitor nutrition? Doesn't matter how old you are. You monitor height. You're going to be monitoring weight, and then whatever sort of blood specimens that we need for it. These children can have the highest fat, high calorie, highest protein, whatever they want, because they're going to eat this much. So if they eat just little amounts, give them the most nutrition as we can in the smallest amounts. Their mouths down into their rectums and even their intestines become really sore. They're going to, not tolerate food. Again, sometimes with all of the medications for the pain, and they're going to get constipated and they're going to push. Be careful of things like they're going to stroke because they're pushing so hard. So try to prevent that with stool softeners with them. And again, giving them their pain medicine as they need. Sometimes even their urine will get blood in them. And I think the one thing we always think of is when you have a child or an adult on chemo is they're going to lose their hair. That's why I always had little ribbons in with me. It would have all the colors, and we'd sit down and we'd make, okay, what headbands are we making today together? Or does your sister want one? Or did she like that color? Oh, she don't like that color. Okay, let's do this together. And again, this kid thinks putting a cute little ribbon on, she don't care. She doesn't have, her hair as much because we've made it now fun. I mean, how many fathers and brothers have shaved their hair for their little sisters and brothers? It happens quite a bit. Another thing is steroids. We give a lot of steroids at this time. Again, remember Cushing's, and it gets big and swollen and very uncomfortable. Again, preparing them for procedures, as I said, if they're sedated, even making sure that we do everything to have things as painless as possible. And for these children to be educated on their developmental level, what's going to happen. Pain management, so important. You know, the one thing a child will remember is that they're in pain. Doses titrated, just titrate them, titrate it, and just to give them enough to get them what they need, because we don't want them constipated and nauseous from so many narcotics, etc. You know, today in children, it's even in adults, but most children, let's get them with health promotion, right? Making sure that they get dental checks, make sure they get their immunizations. Know that just like adults, live immunizations are not going to give to children as immunosuppressed, right? Those children on chemotherapy, they're not going to get them. They're not going to be done until after they're out of their treatment, and then they can. And again, any immunizations on family, they need to check with their doctor. Can I do that with this child on chemo? Now, this is an interesting topic for me. It's Hodgkin's and non-Hodgkin's lymphoma. And I'm going to describe them to you, and I'm going to try to make you understand which one is which and how to remember which is which, because they're just about the same sort of, all right? So Hodgkin's disease is a neoplastic disease in the lymph nodes. It can metastasize everywhere. Now, Hodgkin's disease, it is a cancer of the lymph nodes from the neck up. Do you see that big bulge coming out on that child there, both of them? You can see it, you can feel it, you can touch it. It's a house, it's your lodge. You can touch it, you can see it. That's Hodgkin's. They're big sort of lymph nodes. They're not tiny. Now, what you'll see with these children is they're starting with this is getting bigger, it's pushing over, it's causing me that trachea to push, getting this cough, then you're getting, you don't feel good, it's hurting your stomach, pushing your esophagus, then you start with weight loss, anorexia, night sweats, and then they see this big lump. All right. They go ahead and they do a biopsy, a needle biopsy, usually, of course, under sedation, not just, you know, let me do it right now. Nope, it's all set up well. And they'll see Sternberg Reed cells in it. Remember, Hodgkin's is above the shoulders. You can touch it, all right? It's a lodge, it's a hodge, it's a house in there. What do we do to treat it? Well, this big thing has to be shrunk. So let's do some radiation or maybe chemo, no radiation. It all depends. And they'll go in and they will do surgery and they will remove that cancer. Okay. And they'll be, you know, of course, it's the chemo, the radiation with the surgery that will take care of it. There is a high risk for infertility with this disease. Now, Hodgkin's was above the shoulders, big, thick. It's a hodge, it's a lodge, it's a house. I can feel it, I can touch it. Non-Hodgkin's is not a house, it's not a lodge, it's diffuse. So do you see the pictures? It's in the groins, it's in the armpits. Yes, a little bit in the neck, but it's you can't touch it, you don't see it. Now, usually this sort of thing is already looking like leukemia and studying it. They do try to do a biopsy on it. And again, same thing, chemotherapy, radiation, but they can't remove this one. This is all over. It's like the same sort of treatment like leukemia. Brain tumors. Something in the head starts to occupy space. What will you see? Well, all of a sudden you might see the head getting bigger, hydrocephalus. An older child might be headache and vomiting. And the headache waking you up from your sleep. Vomiting, not related to eating. Sometimes it gets into the eyes and you might see the eyes start moving, you know, because it's pushing outwards. Sometimes it's your gait gets weird because it's hitting, you know, your motion place in there. But what about things like diabetes insipidus? Remember, it's pituitary gland in there. It's probably, attacking that too. And with all of that, pituitary gland growth failure could all be a part of this stuff. So how do you do a brain tumor? Well, you're going to do it. First, you do the x-ray, you do your scan, your MRI, and you're going to go ahead and if you can, you're going to have it removed. Now, if you have, the tumor removed, again, to shrink it, they might do chemo, they might do radiation, they might do all the above, but they'll go in and they'll remove whatever tumor there is left there, okay? Now, the thing about nursing care post-brain tumor, very important to follow the doctor's instructions. You need to position them, whether it's only to 30 degrees, only on the operative site or not the operative site, or put that brain drain, as we call them, to suction or not suction. I mean, these are very, very clear things that we need to be prepared for. Now, neuroblastoma, it's a tumor in the abdomen that gets really big, and before you diagnosed it, it's already in the brain. Neuroblastoma. And it's usually you start seeing things going on with the eyes being pushed out with this brain tumor, and then you feel the abdomen and you find it. This is an extreme picture of what an abdomen looked like. Most of all, it doesn't look as big and hefty like that one. Well, again, this one here, we're going to do the chemo, the radiation, and we will be doing the surgery on them. Some of them, depending on how far is it in the brain already, is it only in the abdomen? It all depends on, where it is for that child. Bone tumors. Bone tumors are interesting. Bone tumors most of them can be cured, which is a great thing, okay? One of the things that you start to see with people with bone tumors, especially in the legs, the one we're going to discuss is an osteosarcoma of the femur bone. Well, these are children that all of a sudden start to limp a little bit, and it gets worse. And then it starts to be with pain, and then, it gets worse. So they go in, they get this information, do the x-ray, and they see this little fuzz on the side of the bone. Now, you have all of the other symptoms going on here, and they've got to take this bone out. Now, you can't just take the cancer off. This is not like a mass that you just take the mass out and the bone stays. You've got to take the whole bone. It's the whole thing got to come out. So what they do is they do something what we call salvaging the limb. They get rid of the femur bone, gone. They take the bottom bone from the kneecap, put it up, turn it around into the hip bone, and have that foot facing backwards. And you see that picture down there? Then they can put a prosthesis on there. If you can imagine, they can't take the femur bone. If they take it out, they can't reattach it. Where are you going to put a prosthesis? How is this child, this adolescent, going to be able to move around? So salvaging the limb sounds horrible, doesn't look nice, but it's better to walk around on something than not being able to be ambulatory, okay? Now, if they can't salvage it, it will have to be an amputation, but that's the goal. All right, another tumor is called Wilms tumor. This is a tumor of the kidney, a nephroblastoma, okay? Kidney tumor. This is a child, doesn't hurt. He will have this little tumor in his abdomen. I had a little boy come to me after the Haitian earthquake, and a religious group got him over, and of course came to my ER one weekend. And this child, and that the records were all in French, so I couldn't read them, and I couldn't even talk to this little 3-year-old boy. But I got to him. I had to do an assessment. So I sat down below him. I gave him a sticker, I gave him a little tickle. I let him look at my stuff, and I was able to do a complete assessment. When I got to his abdomen, the left lower quadrant had the size of my fist, hard tumor. And for some reason, I had never seen it, only once in my career. This time, I didn't know what it was, but I knew what it was then. It's like, this is a Wilms tumor. Can't touch this one anymore. Wilms tumor are extremely fragile. You touch them and they'll move around. You do not do biopsies because that little hole will leave a leakage, will go into the abdomen and cause metastasis. We do, again, these children, we're going to do radiation, we're going to do chemo, and then we're going to go in and get rid of this stuff. That's the incision they do. They go from the front into the back. Your kidneys are on your back. That's the last thing before your skin almost. So it's a big, big surgery. So preoperatively, we just get them ready. Do not touch that abdomen, leave it alone. And there's going to be signs everywhere. That's the biggest, biggest nursing care here. And then post-operatively, after that incision, because they had to go through the bowels, you've got to monitor bowel function. They could have a megacolon here with all of that manipulation, and we'll be monitoring urine output because remember, it's a kidney tumor. Retinoblastoma is what we call a cat's eye. Again, I've only seen one of these, and it was a little girl about 10 months old. And I walked in the room and I saw it instantly with the light. It's cancer. And it's one of the things that with retinoblastomas, part of the assessment, was there anything that happened to the eye? Have they had any infections or anything, hit the eye, any injuries, etc.? Very important that we get that, right? Now, this is a retina tumor, so it's right into the eyeball. So they're going to take radiation. That's what that little mark is there. Never, ever wash them off. That's where they're going to put the gun the next time they go in. And then they go in there and they're going to take the whole eyeball out. They have to. Again, it's like the femur, it's got to go. Now, in high school, I had a boy who used to take his eyeball out and roll it around the desk. I'm thinking, did he have a retinoblastoma? It's like I never remembered it until I saw that little boy down there. He used to take it out. So I just, that shock value for people. And we just got used to him, so we wouldn't look. Again, these children, we can put an eye in, we can make them almost normal, but get rid of it, and we'll have a long chance of life here. Okay, another story. Germ cell tumors. This is testicular cancer. Remember, women do our monthly breast exams. Men should be doing testicular exams. I had an 18-year-old boy come into the ER, into triage, and he complaining of testicular pain. And when the other nurse in the room with me, who was assessing him, had a softball-sized tumor in his testicles, and he was already metastasized. They did the ultrasound, saw it. They did an x-ray of his chest and abdomen. He had tumors everywhere. And I understand that he died 3 months later from a testicular cancer because he was too afraid to come in to be checked because it was his private part. Liver tumors, probably of all of them, you could take out a piece and our body will grow back a new one, right? Not as bad. Knowing today that cancer survival is beyond what I ever knew when I first started becoming a nurse, and knowing that we just have to keep up with all of the happenings that are going on with it. And of course, the other thing with any of these critical, life-threatening diseases, keeping that child, trying to keep them up to date with their growth and development and helping them through these times. I mean, our goal is always cancer-free. It really is. Any questions? They're all one came up. There we are. So who would like to win today? I think Chanel, it's your turn to win.
Ah,
She laughs.
yeah.
And she laughs. Okay, Latoya is gonna win. All right, let's get going. Week 6. What is priority treatment for a newborn of an HIV positive mother? What is our biggest concern about mother and baby and HIV? Always remember those triplets I've told you about. One with HIV, one with AIDS, and one was nothing. It was a clean, perfect health. And that whole thing is just to improve their infant's immune system so they can fight against it. What are symptoms of sickle cell anemia? So sickle cell anemia, okay, think about it. If a blood vessel stops and blood can't flow, it's going to cause swelling and stagnant of fluid in their hands, feet, if that's where that sickle cell attack is. It could be a pain is always there, could be vision delayed, could be headache, could be so many different things. Pain is always involved. What kind of hematocrit was someone with sickle cell have and why? So if you remember that list, sickle cell had an increased blood cell destruction. Their cells don't last long. So what happens is their cells burst quickly. So remember, sickle cell children always in crisis. If you ever work in an emergency room, you're going to see, in adults too, hemoglobin hematocrits will be low. Probably be prepared to give a transfusion. What is the nurse's priority with a child with sickle cell disease who is currently experiencing a crisis? What do you do first? Priority. And then I'll ask you this, are you going to treat the symptom or treat the cause? And the answer is you want to treat the cause. And you treat the cause by giving fluids. Now, it does not mean in this hand I don't have my pain medicine, but your priority is to get the IV fluids, dilate that blood vessel to get those cells moving again. Put the heat on it, get it dilated, get those cells moving. But there's your pain medicine because it does hurt. These kids are in tears. What is the reason children with iron deficient anemia are easily tired? Well, what is iron deficient anemia? Iron deficient anemia, I don't have red blood cells. Oops, I don't have red blood cells. I don't have oxygen or iron. So I don't have my red blood cells. Good job. Multi. The nurse is teaching about newly prescribed iron supplementation. What should she include? I did see some sort of variation on this question on your HESI, or they were talking about iron supplementation. I don't know what the question was, but I'm sure it's something to do with this here. on an empty stomach with orange juice through a straw. It's going to turn their stool black. Never, ever, ever with milk. Never with meals. It's an empty stomach. Very good. Very good. Aplastic anemia includes a depression of which blood cells? Where I told you treat it very similar to leukemia, aplastic anemia. Well, anemia, go right there to red blood cells. Absolutely, that's going to be there. But we know it's a mirage of them. It's RBCs, WBCs, platelets. So children with aplastic anemia, treatment's going to be like leukemia, right? Chemo. Our red blood cells are low, so we're tired, we have no oxygen, we're weak. Our white blood cells are low, we're going to be set up for infections. Platelets are low, you're going to be watching for bleeding. When you're thinking of those cells, that's the way you need to think about what these cells do for the body. Most common type of anemia is iron deficient anemia. Thank God it's not aplastic. What causes pernicious anemia? That's the intrinsic factor. Again, how do we treat this? We give B12 injections, right? We don't have it, we need to give it somehow. Very good. Which symptom is the single most common symptom of anemia? I think it's the parents coming in and say, my kid's tired, there's something wrong with him. He doesn't have the energy like he normally has, right? That's what you would say, fatigue. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for. Remember, thalassemia is destruction of blood cells. Their red blood cells burst like fast. And the treatment is transfusions. What's inside a red blood cell? Iron and oxygen. So what are they going to be at risk for? All that iron. What are they going to do? How are we going to treat it? We are going to be treating that with iron chelation therapy or that apheresis machine. Let's pull off that iron. Thrombocytopenia is ITP. That means low platelet count. What lab values will you see with hemophilia? What will we be looking at? You know, as I said, if you're suspecting hemophilia, they're going to be pulling all these factors in a CBC. But the other thing that they're going to be pulling is your bleeding coagulopathies. With hemophilia, your PTT is elevated also. Platelets are absolutely normal, and so is the PT. And that's usually where the clue comes, okay, we're going to be dealing with hemophilia and make a plan from there. What is immune thrombocytopenia purpura? Remember, ITPP, what does that mean? Remember, ITP, we usually find after nosebleeds because their platelet counts are really low, following some sort of upper respiratory. Very good. And you're going to see the petechiae. You're going to be careful bleeding precautions with that child. So thrombocytopenia can cause the following symptoms. Petechial hemorrhage, ecchymosis, epistaxis. Yes, very good. A multi. Child with hemophilia has fallen, the knee is swollen and painful. Treatment would include so We are not going to put any hot packs. We don't want to dilate it and make it bleed more. We don't want to exercise it because exercising will make it bleed more. We're going to rice. We're going to rest, ice, contain, and elevate. What is the priority nursing action for a suspected blood transfusion reaction? What do you do first? Turn it off. And even if they come and say it's not, you protected the child, the patient. That's all that matters. A child is admitted with neutropenia. Which nursing action takes priority? What does neutropenia mean? Neutropenia is a low white blood count. What does that mean for the child? They have no immune system or a decreased one. What would you do for that child? Hand washing. It starts with hand washing. It doesn't have to be contact in an isolation room, none of that. Hand washing. Which symptom would a healthcare professional expect to see in a child with leukemia? Remember, their white cells are low, their red blood cells are low, their late platelet counts are low. What does that cause? So they're going to be bruising, platelet counts are low, fatigue, red blood cell, bone pain, it's just part of the disease. Very good. Your child with ALL has had recent lab results with platelets counts of 10,000. Nursing action. What does 10,000 platelet counts mean? And I don't care if the child is ALL or just came to the hospital or had surgery or a platelet count of 10,000, any patient. What is your concern? Remember, when you talk about platelet, you're talking about bleeding. This is that child that's on bleeding precautions. Very good. A multi. A child is placed on bleeding precautions for ITP. What interventions would the nurse do? So we know low platelets. We've got to be careful with bleeding. How are we going to monitor? Little bit of everything. Don't forget the corticosteroids. One of the important components of ITP. It says symptomatic. Most of the times I've seen it used, but no injections. Look for bleeding. Monitor that CBC. Absolutely. Child with Wilms tumor. Which action by a nursing student causes faculty members to intervene? As in, what did the nurse do wrong? Right? This is one of those other questions. Again, leave that abdomen alone. You're going to have in front of the chart, on the end of the bed, on the top of the bed, put a message on his forehead. That's so important because that tumor is so fragile and just manipulating it can cause metastasis. A child with ALL has a fever of 100.5. What should they do? So let's say this kid's at home. He has a fever. He has leukemia. What do you think they need to do? Any child with a decreased immune system that has a fever of 100.5 or greater needs to call the doctor or needs to go and get treatment. Most of these children, especially ALL, where they don't have any sort of white count, they need to get medical attention, and they probably will give them a dose or two of IV antibiotics because they are so immunosuppressed and they are up for septic shock if we don't. A child is having a bone marrow aspiration. What should you tell the child? I think you all know this well. It's always take care of the kid, give him a hug, say, I'll make it as best as I can, and I'll hold your hand for you. I mean, that's all kids want is to feel that somebody's there with them and they're not alone. Most common clinical manifestation of a retinoblastoma. I always relate this as in going outside in the dark and there's an animal and you see the shiny of their eyes. It looks just like that when you look at the eyes. That's why they call it a cat's eye reflex. Your child has been diagnosed with a retinoblastoma. What information is important? What do you need to know about this child? You want to know if there's been anything going on with that eye. It might make a difference, okay? Many eye infections, it's that and more. And that's why the blue one is more appropriate. A goal of surgery for a child with an osteosarcoma is this is the bone cancer of the femur. And you can see how it's like bows out. You could see it there. A lot of times it starts around the knee and they think they've strained their knee or something. So the one thing and the goal is to try to save that lower leg so that we can reattach it for a prosthesis. Absolutely the goal. But if we can't, then we're going to have to do the complete amputation. We prefer not to because we want a place to put prosthesis. A child's complaining about the skin markings for radiation therapy should be told what? Remember that little purple mark above that little kid's eye? It's bothering me. What are you going to do about it? Leave it alone. I would say, after all the therapy radiations are done, let's have a skin washing party, with a cake that it can come off now. I mean, make it into something, distract it from something bad. When distraction is used, it helps. The one thing I always did, especially when I worked up in the NICU and the cardiac ICU, is I would have music on at all times. And I worked night shift. I'm an old night nurse. And those kids would sleep all night long. Again, they're not knowing what's going on. They're somewhere else and they're thinking about whatever the distraction is. So they're not going to be focusing just on that pain. What assessment question needs asked to a child with possible rheumatic fever? I'll always go back to last week with a couple of questions. Any sore throat. Remember, rheumatic fever is one of those things caused by strep throat. We're going to find another one caused by strep throat on week 8. Signs and symptoms of asthma. Everything. Yes. Coughing, wheezing, short of breath, expiratory. Remember, it's all expiratory. Multi. What symptom should be reported to the healthcare provider for a child with sickle cell disease? I think what this question is asking, what are the symptoms that you'd be really concerned about, other than the obvious that occurs with most children? And that is the chest pain, that is the severe headache. Yes, we're going to tell them hands or feet, but I have to reword this question. The thing I was trying to say is the ones that are most concerned is it in the chest? Is it in the head? Is it a stroke? Making sure that child is safe. Absolute contraindication for nasotracheal suctioning include which of the following? So it's everything. Anything that you have in the mouth, any swelling, epiglottitis, croup, anything, nothing in the mouth. You don't want to increase swelling or increase bleeding. Iron dextran is given via which route? Now, we talked about oral iron, and we went over all those things with this. Iron dextran, interesting medication. Do you know this was the first IM injection I gave as a student, and I had to give it to a young 40-year-old woman, and I was so scared. It is a brown liquid that does burn on the skin. You have to do a Z track. Pull it up, put it in, easy, out, lock and load, I call it. And it is, I am deep with a Z track to hold it in there because it burns and we want that medicine to be there. If a child was to receive their own bone marrow, this is called a what transfusion? Remember I told you, what are the little names and tricks I gave you? Automatically mine is the best. Mine, autologous, automatically mine. Everybody else is all the others, allogenic. What cancer may present with a painless, firm, enlarged cervical nodes? Here. And that's Hodgkin's lymphoma, very good. A multi. When teaching about sickle cell disease, you would include well, sickle cell disease, we know it's caused when the blood vessels shrink up. Blood vessels, the cells can't get through, creates these crises. So, what do we need to teach about? We need to teach them to drink the fluids, take their medicine, because they're given like little Tylenol number 2s or number 3s, they are, and they send them home. When they start to have pain, they start with that so they don't get behind. Also, when it's cold outside, you're going to constrict. You want them to keep it nice and warm. And of course, they got to go for medical care for any fever over 100.5. Thalassemia major is treated primarily with what? So thalassemia is the bursting of the red blood cells, iron and oxygen go in there, and the only way to treat it is blood transfusions. A multi. Treatment of osteosarcoma includes so the only thing it's not is a stem cell transplant. It has nothing to do, it's a bone with a cancer on it. We've got to get out of there. So we try to keep the part of the leg to use it, or we amputate it. And yes, chemo and maybe radiation to shrink it. A multi. Who are the best donors for bone marrow transplants? Well, I told you it doesn't matter the type. There's not an A positive or O positive. It doesn't matter if it's, from the family or not. But we know number one, you're the best. Number two is actually the siblings. Those are the two best. The other ones, not as much. If you have the siblings, same mom, same dad, that's your second best. What is the most common opportunistic infection for children with HIV? And it's that PCP pneumonia. Probably second up would be some sort of yeast infection somewhere. What would you consider to be neutropenia or a low neutrophil count in children? So remember, neutropenia, low neutrophil count, low white blood count, no ways to fight infections, get a fever, and these children are going to go into shock. We need to know that that number, 500 less, we need to treat that patient first, take care of it. That is your priority. A primary characteristic of a brain tumor is, so you've got a tumor in the brain and it's growing, taking space up in there, slowly or fast. What do you think this child would be feeling? We're going to see it being growing, and the symptoms are becoming worse over time. Headache, waking them up at night. Vomiting, not related to eating, okay? And then it wouldn't be good balance. You probably see this child falling over because of where that tumor could be. The optimum treatment for an osteosarcoma is, optimum is to salvage the limb. Remember, you cannot just take out the tumor and leave the bone. The whole bone must be removed. If it's the femur bone, it's the whole femur bone. Last question. Child is receiving the induction of chemotherapy. What does that mean? Remember, that's the first 4 to 6 weeks of chemotherapy. And it's initial intense chemo, and it's the goal is remission. Yes, we do 3 more steps, but it's to make sure that there's no cells in there. How do we do today? Time for bed. I like that. Good job, Shay. Number 1, drum roll, please. Brenton. Good job, Brenton. And Lala, see you were there, Lala. Night, night. I love it. Anyway, guys, you got out a little bit early tonight. I always appreciate you all. Remember to give me what you want to do for your pediatric assessment assignments, your project. Send it to me so I can okay it for you. It doesn't have to be on that list. It could be any childhood condition, medical condition that you want to know more about. You had, your child had, your sister had, something you've seen, something you want to know more about. Those are the best ones to choose, okay? I will see you all tomorrow if you're here at 2 o'clock for my review, and I'll send it. Have a great night.
Good night.
Good night, everyone.